Thank you very much, Robbie. Again, thanks for the invitation to be here. For those of you who have seen some portion of a furosemide stress test talk that I've given already, I will be a little bit briefer than usual. For those who've never seen it before, it'll be a little faster than you probably would like. And that's to stick to being on time. And I have some new things I want to share with you about some thoughts on how we think we can make this work a little bit better. By way of disclosure, I am currently on sabbatical on the dark side. I am the chief medical officer of a publicly traded company that has nothing to do with the talk that I'm about to give, but you all should know about that. So stress testing is something which we're all familiar with. When we're all interns, we all learn how to do this in cardiology. And for acute coronary syndrome, the way we do this is well codified. And there's many a cardiologist who's made their career on, is it a dobutamine stress test, a treadmill stress test? Is it dobutamine thallium? Is it echo thallium? Is it echo dobutamine thallium minus adenosine, or whatever the concoction happens to be? The point here is that they have a very robust series of stress tests that allow them to work with their disease. And so one of the things that we decided to entertain was the notion this could work for nephrology and for acute kidney injury in particular. And so because most acute kidney injuries, or not all, but most acute kidney injury involves a tubule, we sought to develop a tubular stress test. And if you think about what part of the tubule is of most interest, it's clearly the S1, S2, and S3 segment. Based on preclinical data, we believe the S3 segment is the most vulnerable. That's not necessarily the case in all models. And as John Kellum has consistently argued, the clamp alone is probably not the only way to make this assessment. And certainly with septic-induced AKI, the way the tubule behaves is quite different than a pure ischemic model. But in order to assess this, it turns out that furosemide is an excellent probe. And the reason why is because furosemide is not filtered. Furosemide is very tightly bound to albumin, and it has to be actively secreted in the proximal tubule by the organic anion transport system. And so if you want to interrogate the proximal tubule, a very reasonable way to do this is to give furosemide, because in order for the furosemide to get to the lumen to do its thing, it has to be actively transported across. So we sought to develop a stress test based on this notion, and the idea was really quite simple. If you give a furosemide in a standardized fashion, something which people have been doing in an unstandardized way for about 50 years, depending on the decile age of your training, the dose of furosemide you give before you decide to dialyze the patient is variable. If you've been to Woodstock, it's somewhere in the 250 milligram to gram range. If you know who Kurt Cobain is, it's somewhere between 100 and 250. And if you don't know who Kurt Cobain is or Woodstock, it's under 100 milligrams, right? So there's this variability based on your age, personal experience. And if you don't know who Kurt Cobain is, I usually don't have much in common to discuss with you. But nonetheless, there is this sort of where you've trained and how old you are, how fearful you are of furosemide metric. So we decided to make this really simple. If you have a KIN 1 or 2, you basically get a standardized stress test, and it's 1 mg per kg, and we sought to make sure these people, to the degree that it was possible, were volume replete, and they weren't classically, quote-unquote, PreRenal, a term which I despise, which I will assail later in the talk. And we did this by looking at CAS and by looking at the dreaded FENA, and we excluded the usual suspects in patients with advanced CKD. And we published these data in Critical Care some 2 years ago now, and what we sought to demonstrate is, does the simple test that's been going on for 50 years but now standardized actually inform you about something which is of importance to all of us clinically, is are you going to progress from stage 1 or 2 to stage 3? And this is not legible, but this is just to show you that these are the patients that you actually care about. They have comorbidities like CKD, hypertension, diabetes, and heart failure. Their exposures are the usual suspects: NSAIDs, aminoglycosides, contrast, post-cardiac surgery, sepsis. And they have the appropriate Apache 2 score range, which you associate with critically ill patient, although these folks weren't profoundly critically ill with a mean Apache score of around 18. And what we showed is that there is an enormous difference between responders and non-responders. So if you respond to furosemide, you do better. If you don't respond to furosemide, you do worse. And Michael showed you some very beautiful data about baseline urine output, and the reviewers were quite particular about this, and we did a subset analysis I'm not going to walk you through, but the furosemide stress test is more informative than baseline urine output alone. So perturbing the system, stressing the system, if you will, or making it do something is more informative than a static model, which is not uncommon in clinical medicine. And basically what we found is that, much to my surprise, because my initial idea was to add biomarkers 2 furosemide stress tests to get the AUC value of 0.87, which is what we got with furosemide stress test alone. And so this very simple test that we've all been doing for 50 some odd years is actually quite informative, and it operates at a very good level. So for those of you who don't spend your lives thinking about and obsessing over ROC curves, let me put it to you sort of in very plain sort of scale. Troponin, which we think is probably the best clinical marker, lives at an AUC curve value of around 0.91, 0.92. So anything in the 0.9s is gold standard, outstanding. Anything above 0.8 is really quite good. Anything above 0.85 is very good. 0.75 is good enough to work with. So CKNB lives around 0.86, 0.84, 0.83, depending on the series. And tests which are really poor, like FINA, live at 0.65. So the only reason I mention that FINA is so terrible is you can't like FINA at 0.65 and hate NGAL at 0.79, just to be intellectually consistent, but that's an aside. So if you care about diagnostics and you're going to be interested in diagnostics, I think we should adhere to an intellectual construct that's consistent. So we then looked at biomarkers to compare them in this set, and what we found is that furosemide stress test, as I just showed you, reported 0.87, and it did much better than a lot of the other sort of biomarkers that we think was contemporary. And so people have assailed us and said, oh, you guys have demonstrated biomarkers are worthless, we're going to throw them all away. And so I think that was certainly not the point we were trying to make, and I think the important point that we actually show in the paper is that they actually work well together. The issue here is that the biomarkers that were being used deep into AKI, AKI stage 1 and stage 2, is not the same as early biomarkers of AKI, and those have an important role. This is another phase of AKI, which is about recovery and prediction of improvement in outcome. And what we did is that we basically said that this is a good pilot, it's in a decent size set, and it basically confirms what we already knew, that giving a standardized set of furosemide to a group of patients is informative. And I think that David has actually said this quite well, that this is something which has been done before, and we've added some rigor to it so we can actually put some metrics around what the dose is and what the readout is to make a decision. But there's a couple of important issues here. Number one is we replaced the urine output CC for CC because you can hurt people with high-dose furosemide. So one of the things that you really ought not to do is ever do this in an ER. If you're doing this in an ER, something very, very wrong is going on with the world, right? This is something you do once you are reasonably confident your patient is appropriately resuscitated, and as Michael mentioned, you would like them to see them be no longer volume responsive, in my view. And I think it's very important that this not be used as a first-line test. You say, what's the big deal? It's only furosemide. Yeah, it's only furosemide, but you know what? You can really still hurt someone with it. So I would like to see this be a test very similar to the way we use stress testing in cardiology. You use your clinical brain, you make a clinical readout of what you think is going on with the patient and what their a priori risk is. In a Bayesian way, you then use a biomarker to help you with that next decision point. And if there's remaining uncertainty, you use some sort of stress test, doesn't need to be FST, whichever one you think is most validated, to help you confirm. I think this is a very tried and true kind of thing we use in clinical medicine. I think we should continue to do so. And, you know, the framework for this is however you codify AKI risk, whether you do it with renal angina, whether you use it with a risk scoring system, whether you use it with a point scoring system, I'm pretty agnostic about it, but it does need to be rigorous. There does need to be a process by which you say to yourself, what is the pre-test probability of this person having acute kidney injury? Some of you recall this really archaic test called the VQ scan. It was used like, you know, decades ago. And you had to write down your pre-test probability on a piece of paper before you could appropriately interpret what the VQ scan meant. And that's not just for VQ scans, it's for all of clinical medicine. And so however you decide to do that framework, it is important to understand and codify your pretest probability. And so if you do that and you use biomarkers, so what we did is we took the same set of data and we said that if you remove the low-risk people, so if you take a nephrocheck value less than 0.3, or if you use an NGAL level less than 150, because both of these values have a very high negative predictive value, you remove noise from the system. And when you take these people out and you run the FST, its performance goes up to 0.91, and that's where troponin lives. So the point here is if you use your test, if you use what you have together, cognitively based on your pretest probability, not surprisingly, they improve performance. And so I think this sort of like boxing competition about who's got the biggest number or best number to post on the paper in the top journal does not help our cause. You fundamentally have to clinically assess these patients and use these tools thoughtfully to make interventions. So we believe that these two can work together, and I certainly agree that this needs to be validated in larger studies. Jay Coyner and a large host of Kathleen Liu, Biome is also working on large validation trials for this right now. Now, I think one of the greatest sins that's occurred in the past 30 years in nephrology is the fact that most internists, and certainly anyone outside of internal medicine, believe that these two things are the same. So it's essentially a diagnostic crutch. You don't know what PreRenal really means, but it does buy you an extra day to get everyone off your case for the patient's creatinine who's gone up. You give a liter of saline, you make him a little more acidemic, and then tomorrow you get to be, similarly, not involved in your patient care the way you ought to be. Let me be polite about it. And then you get to have another day of another liter of saline, and now you've reached the point where you actually got to call somebody. And now it's 48 hours. And do you really think those cells have a chance of coming back after you've blown them off for 48 hours? And I think the answer is definitively no. So this is a problem because for most people, low FeNA equals give saline. And we are, at least in part, responsible for this terrible education that it runs rampant throughout all of clinical medicine. And I don't know how to fix it. I mean, I can, go on a rant, at least twice a year about this, which doesn't really help the cause. But we fundamentally have to do better than a test that scores at 0.65 on ROC curve value, which is pretty close to a coin toss. So if we have modern tests, I think we ought to use modern tests, and we should dispense with tests that are not informative. And we should stop the disinformation, which leads to fluid overload, which at least now everyone agrees is potentially bad for you. Now, if you think about a classic pre-renal situation, we think about decreased renal blood flow, and we know the FeNA is low because the proximal tubule is able to reclaim sodium. Okay, so that's cool, that makes sense. Well, that's true. You have a low GFR, you have a low urinary sodium, and you're oliguric. But if you can resorb sodium, you can secrete furosemide. It is a two-way street. The proximal tubule does not sort of just throw up a strike one day and says we're only going one direction, not the other. So it has enough ATP and enough blood flow to resorb sodium, it can secrete furosemide. So we believe that people who are pre-renal, though oliguric, likely have preserved furosemide secretion. This is a hypothesis. Now, if you look at biopsies of patients with sepsis and acute kidney injury, this is what the KIM-1 staining looks like. And let me show you what you're not seeing. You're not seeing ATN. What you're seeing is patchy injury. So what does patchy injury look like on a FeNA? What portion of this kidney are you actually sampling when you look at their urine? I don't know. Do you know? I don't think anyone knows. So the question we have is, well, this is your kidney with patchy injury, and this is the area that's producing urine. Maybe this part is effectively able to resorb sodium, but it's only 1/10 of the available nephrons. That segment will give you a low GFR, low urine output, and a low urine sodium. This is the person who gets saline, usually 3 to 4 liters, who shouldn't get it because they're not going to get better anytime soon, and certainly not from volume loading. They too, in that segment which is working, we believe, as a hypothesis, can also secrete furosemide. But the overall balance of furosemide they're going to be able to secrete with 1/10 the nephrons should be decreased. So we think looking at the urinary furosemide could be informative to delineate A versus B. And so to show you what this might look like is you would have this kind of injury, poor furosemide secretion, and this type of classic pre-renal as having more preserved furosemide secretion. And so this is a hypothesis we're actively investigating, which is can you differentiate clinically, because giving furosemide is pretty straightforward and measuring it isn't that hard, and I can talk about the assay in a little bit. And this is just 2 patients from our trial. Some of you have seen these data before, and for those of you who've seen it already, I apologize for the repetition. But what you're looking at is 2 nearly identical patients. They're both 73 and 67 respectively. They're about the same weight. They both have postoperative AKI, and they have similar Apache 2 scores. They both have FeNAs under 1%, and they both have lots of CAS based on their CAS score of 3. They look pretty similar, and they got nearly the identical dose of furosemide with a very similar urine output. but the amount of furosemide as a percent of what they secreted is quite different. Now, I don't know what this means, but I suspect it's highly informative. And I think this is something that we need to actively investigate, because when you perturb a system, you typically get more information than a static system. And if you then actually think about this idea, this is the idea of sort of, instead of single nephron GFR, we're proposing idea of sort of representative tubular reserve. Do you have a tubular reserve? And is there a proximal tubular reserve or a distal? And can we use a combination of furosemide secretion and biomarkers to help us ascertain where the injury is and to what degree? Now, what you're looking at here is a scattergram of the urine output as compared to the percentage of furosemide excreted. Now, for normal people, for everyone in this room without kidney disease, this is highly linear. The more furosemide in the urine, the more urine you make. But you have these people over here who put out a lot of furosemide. They're putting out nearly 30 or 40% of the furosemide that's given, but their urine output is poor. These folks maybe have intact proximal function and more dysfunctional distal injury. I don't know if this is true, but it's something which you could at least have as a supposition. Whereas these folks, only less than 15% of their furosemide is excreted. And one patient made 5 liters of urine in 6 hours. So is this person proximally dysfunctional and more intact distally? I'm not sure. But I do think this is something worth assessing. So you think, okay, this sounds really complicated. How am I going to actually know who has injury where with a biopsy, and then I do this interaction and I know what it means? And I think that that is a critical question. So stress testing is interesting, but how do you put this together into some sort of format that is actually useful across large groups of patients? What we really want to know is, can we figure this out without having to put a needle in their back? That's what we want. That's what we all want, because putting a needle in their back when you're in the ICU with lousy platelets and shock and Levophed is not so bueno, right? So we want to find some other way. Well, I think that this could be a way that you could use a non-invasive functional biopsy. But I think that it's important to recognize that a stress test alone will not give you these data. And I do think a combination of stress testing with biomarkers is a highly reasonable approach used in many other disease states. So the brief summary of this construct is that functional kidney testing, I think, clearly has a role, and I think this requires substantial more work to sort this out, and I think it needs to be done with biomarkers to give us prognostic data and hopefully phenotypic data. Now, what are the next steps? Well, I think we have to validate this, and I think we need to work on a lot of people. But before I sort of take you through what I think the final thing looks like, I hope you indulge me in a brief diversion. So who here knows what mass spectroscopy is and uses it in their practice at all? Anyone aware? MS? Okay, so I'm going to give an extremely poor tutorial on this in 30 seconds. So what you basically do is you take your sample on the far left and you jam it into a $1.5 million machine. And then what this thing does is it breaks it up into a bunch of little itty-bitty pieces, and then it usually ionizes it. And then you basically get a mass charge readout. Then you take this mass charge readout and you collide it again with something else, and either you do a collision or you do a photon, and then you get another readout. And so basically you take some sample and you blow it up 2 times and you basically do a bunch of different things to it and you get a readout. And this readout gives you this beautiful chemical fingerprint. So what you're looking at is the mass spec of a fatty acid. And if you do this 100 times through the same mass spec, you always get the exact same chemical fingerprint. So when they do discovery in chemistry, and so if you're working in a medicinal chemist and are looking for the degradation products of your drug, they take them, they run them through mass spec, and they know what the chemical fingerprint is. This is what you get. So what I would like you guys to consider for just a moment is think about what a mass spec proposal looked like in study section. What we're going to do is we're going to take everything, every fatty acid, every olive oil, whether it's from Italy or Spain or California, we're going to take everything, run it through this bizarro system, blow it up 15 different ways, and get all the little bitty fingerprints, and we're going to get this giant library. And then we're going to be able to identify everything. Where does that get funded? Nowhere. That's a big fishing expedition. This is not hypothesis generated. This is big data. There's 100 things in all the pink sheets that I've submitted along with my colleagues over the past 10 years. That's what they did. This is modern chemistry, mass spec, mass spec. They have a library for everything. So why can't we have a library for AKI? So they said the imaging is no good. Well, we know that the renal circulation is preferential to the cortex. These data, these images are compliments of Steve Texter at the Mayo Clinic. This is what Bolt MRI looks like of a healthy, functioning kidney. And what you're looking at is the difference between oxy and deoxyhemoglobin, because oxyhemoglobin is diamagnetic and deoxy is paramagnetic. So MRI can detect the difference. And what you see in the center here is the medulla has more deoxyhemoglobin, as we'd expect, because it's a place that we have no less oxygen. When you give furosemide, it totally changes its kinetics. You perturb the system, the imaging changes. It tells you something more. So imagine if you did this in a patient who actually had acute kidney injury, and you have a static image, then you perturb it with furosemide, you see what the readout is, and you add biomarkers. You can't tell me that's not going to be informative. And then you say, well, you don't know what you're looking at. Well, I say build the library. So take a lot of animal studies, do your probes, do your imaging, and then most importantly, do it in humans. Take all kinds of AKI, AKI with cisplatin, AKI without cisplatin. This is a big project. It would require something very uncommon in nephrology, which is intense collaboration and playing nice in the sandbox. And you say, well, it can't be done. Well, they did it for mass spec for every single chemical on Earth that we know about. So it's not that this cannot be done, it's that we would have to choose to do it and think it's a good idea, and then simply do it. Because then what you could do is have all your probes with your biomarkers, and then you have your candidate patients with the disease that you have, and then you do your probe, you get your readout, you go to your library, and you know what they have. And I think that would be a interesting way and potentially a way forward to do phenotyping in AKI. And I'd like to thank Juan Bosch, who was ahead of his time with fluoride stress testing, who trained me. And I apologize for going over a few minutes. With that, I'll stop and take questions. Thank you.
I make those very interesting. I have a quick question for you. Knowing what you know already about the combination of FST failure and additive value with biomarkers, would you have a suggestion about how to combine those with percent fluid overload, if you had to suggest to people how they might manage people right now with what's been done, admittedly not validated yet?
Yeah, so that's a really good idea, and I think that we need to be where the pediatricians are in understanding what fluid overload threshold leads to the biggest problems, and we don't have those data just yet. So in the pediatric world, it's pretty clear, and they have some very good prospective data that when you get above fluid overload of 10%, it's bad. 15%, you probably should be started on the filter, and above 20%, you're probably late. And I think that we need to have some better data on where that fluid overload cutoff is. But let's assume for a moment, to your point, that we have it. I think that I would like to see FST be used as a threshold to at least start taking off volume with a device. And I think that would be a thoughtful approach because, you know, if you look at other places that manage fluid overload more aggressively, they have better outcomes if you look at this on a secular level. And I think we need to sort out where that trigger is. But if we were at, let's say, 15 or 20% fluid overload, and there was clinical evidence of a fluid overload issue, whether it be hypoxemia or something else, I think that would be a very reasonable initiation point to start renal replacement therapy.
Thank you. One more question.
Natasha from Thailand. Thank you for a very inspiration talk. Dr. Chawla, if the patients that we saw already make fair amount of urine, do you think the furosemide stress test is still useful to predict?
So that's a great question. And one of the ways I knew that the study was actually going reasonably well is that, you know, I would sit with my research fellow, and we would do the FST, and there's always this sort of bedside betting that goes on. What do you think is going to happen to the patient? And, you know, I remember the first time I had a patient who was making about 60 cc's of urine an hour, which is quite adequate. It was about a 100-kilo patient. And I said, this person's going to be fine, but they met criteria, we're going to do the study. And we gave the patient, you know, 1.5 mg per kg. They, you know, it was about 150 milligrams of furosemide, and they made no urine. They still made their 60, but they didn't increase their urine output at all. And I was really surprised by that. And I thought, well, I don't know, maybe we screwed something up. We'll figure it out. And then 2 days later, the patient's urine, you know, consistent renal function over time just totally crashed, and they ended up on dialysis. And there was a few times there were patients who were profoundly oliguric, And I said, nothing's going to happen to this person. I'm not going to respond to anything. And we gave him furosemide and they had a brisk response. So I would say that this didn't happen all the time. There's a lot of patients that, it happened exactly the way you'd imagine it. But we were surprised sufficiently that I think it remains informative. And we've been doing it anyway for 50 years. There's nothing new here. All there is some parameters on how to interpret it. And like I said, this should be validated in a much larger set. And actually, you'll be seeing some data at this meeting on this.
Nice. Thank you, Dr. Chawla.